Hi, Dr. Jan Huntingford again, talking to you with our second installment on neurological rehabilitation, which, as you probably remember from the first time, is one of my favorite topics to speak about and to teach you about. So in the first part, we went over neurological anatomy and how do we find our lesions. And in this next two parts, we are going to try to figure out how do we fix the problems that we find and some general neurological rehabilitation principles, as well as we'll go over some specific common neurological conditions and their rehabilitation. So here is a list of common neurological conditions that we may see. Now, with our neuro exam and our physical exam, we can find a lot of these issues and we can figure them out. But in some cases, we need advanced imaging. Sometimes we need an MRI, sometimes we need a CT, sometimes we need a neurologist to help us out. We might need to have a spinal tap done, and that stuff is never wrong. But in some cases, we can make a diagnosis or a presumptive diagnosis because not all of our clients can afford to have an MRI done. So this is why we need to think about these things and when should we be referring and when can we make a fairly confident diagnosis ourselves. So when I look at these things, we saw in the previous slide the common neurological conditions that we have. Now with those, I've divided them into things like pain and no pain, and animals that are systemically ill. Because if I can divide them into that helps me determine what the problem is. For example, if I have a dog that is systemically ill and that is painful, well, then I am going to look at things that occur in both sides of my pain and systemically ill. Things like polyradiculoneuritis, discospondylitis, tick-borne diseases. So, this one appears here as well. So I may have a painful animal and it's going to be systemically ill. It's got discospondylitis. You never want to take a dog that has discospondylitis and put it on prednisone, at least not in the absence of antibiotics, because it's an infection. It needs the antibiotics. So you don't want to make the wrong presumptive diagnosis. So this will help you a little bit. And remember, your degenerative myelopathy dogs, they don't have any pain. And dogs who have an FCE, they don't either. So all of these little tables help you to decide what to do with your patient and what the disease process may be. So as I said, we have all of these differentials. How do we narrow it down? Well, I have pain, I have no pain, they were systemically ill. There were still a few things on that list. So what do we do? Well, obviously we want to do diagnostics, radiology, and blood work. We should be doing these. Remember, we need to do our due diligence. And don't forget, so dogs who have discospondylitis, they're going to have an elevated white cell count. They're going to be sick. They're going to run a fever. As opposed to your intervertebral disc disease dog, which may just have pain. They may both have some paresis or some pelegia, but one's going to be sick and the other one really isn't. So that's going to help you out. But advanced imaging, MRI, CT, always available, but in some cases not possible because of the client's pocketbook. So if advanced imaging isn't possible, then I think we need to consider something that I would like to call case-based diagnosis. I didn't make up that term, but I do like it. So how do we do case-based diagnosis? We start with localizing the lesion. Are we dealing with an upper or lower motor neuron lesion? Are we dealing with a brain lesion? So we decide, is it upper motor neuron or lower motor neuron? Is it acute or chronic? Right? So it's kind of like when you do your TCVM diagnosis of excess or deficiency, and which is it? Acute, chronic, excess, deficient? So localization, the onset, progression. Not many disorders spontaneously improve, but you do have to be careful within the first 24 hours because as I was talking about the dog that belonged to my secretary that was over 24 hours progressively getting worse and therefore needed to have surgery, it's important to understand the progression. The client tells you, well, this happened, the dog was normal, bang, outside playing, suddenly can't walk. So that's peracute. And, it's been like that for 24 hours. But not many things are going to improve. They generally get worse or stay the same. So symmetry, not many disorders are truly asymmetrical. If you have a dog who has a peripheral neuropathy, like, for example, a dog with a nerve sheath tumor of the front leg, that's going to be a truly asymmetrical problem, but most of these problems are not. So we look at lesion localization, we look at onset, we look at progression, we look at symmetry, we look at pain, is it painful or not? And then, of course, we look at signalment, right? Remembering not every dachshund has IVDD, although a bunch of them do. Now, then, once we're thinking those sorts of things, how do we fix the problems that we find? Well, neurological rehabilitation is focused on correcting functional problems, addressing the origin, and addressing the secondary problems. So even if you're not sure what's going on, if the dog has IVDD versus discospondylitis versus something else, one thing that we can do is, if the dog's painful, we can treat it. Check the dog's bladder. If it can't pee, you need to help that out. You can prevent skin lesions. You can deal with myofascial pain. So there are many things you can do even before you have a diagnosis. You notice I said not instead of a diagnosis, but even before you have a diagnosis, you as a veterinarian need to deal with these things. So let's look at a clinical case so we can look at this case-based diagnosis and see if we can figure out what happened to this dog. So this is Cooper. Cooper is a male-neutered golden doodle. He had a body condition score of 5 out of 9, muscle condition score 3 out of 3. He was running around like he always did, and he was totally normal, but after he ran for a tennis ball at the dog park, he yelped and he collapsed, and he was unable to use his right hind leg. He went into his regular veterinarian, and they said they did a general physical exam on him and his blood work, and that was unremarkable, and then they sent the dog to me because they realized that the dog had a neurological condition, and they didn't want to take the dog. The owner did not want to take the dog to the neurologist, who our closest neurologist is about an hour away and across an international border. So the dog came to see me. And so when I did the neuro exam on Cooper, this is what I found. Monoparesis, right hind limb. The proprioception was mildly delayed left hind limb and absent in the right hind limb. We had an increased patellar reflex. All the other spinal reflexes were intact. Our cutaneous trunci cutoff was T12. And this dog was mildly sensitive on thoracolumbar palpation. So I diagnosed peracute onset, symmetrical, non-painful, spontaneously improving T3 to L3 myelopathy. Spontaneously improving because the dog was collapsed on that limb initially, and when I saw him, he was trying to walk on it, so it was spontaneously improving. There's not too many things that I know of that spontaneously improve. So let's see what the clinical reasoning of this is. I localized this to a T3 to L3 spinal segment. I know that the onset was peracute. So there's only a few things that are going to cause this. Trauma, was he hit by a car? No. Vascular FCE, maybe. And ANGP, which we'll talk about how this works. Obviously lateralized. It was obvious, so it's still the same 3. But this dog spontaneously improved. So we had some idea that it was not trauma because the dog improved. But because the dog was slightly sensitive on palpation, I diagnosed acute non-compressive nucleus pulposus extrusion, or type 3 disc, you might call it that. Sometimes that's what it's called, as opposed to the vascular FCE, which you could have thought it was that as well. But these ones are not sensitive at all on palpation, whereas these guys are slightly sensitive on palpation. So that's your case-based diagnosis. You look at what you have, you see where it is, does it improve or not, and then it gives you your full ideas. We could do this with many other cases, but this is basically what we did with Cooper, who had acute non-compressive nucleus pulposus extrusion. So what is this, in case that you don't know? Well, it's generally confirmed by MRI, and it is a contusion of the spinal cord, not a compression. And actually, we sent Cooper to the neurologist, or I recommended it, and they did have an MRI, and this is actually what he had. But it is a very specific type of disc extrusion, and it is a sudden extrusion of that non-degenerative nucleus pulposus, which you remember from the spinal cord anatomy that we reviewed, exactly where that is. And it is caused by sudden increased intradiscal pressure. And it is a very common non-surgical spinal emergency, so it's going to be similar to an FCE. The FCE is really like a spinal cord stroke. But the big thing about this thing is it occurs with strenuous activity. And the only treatment is physical therapy, and the prognosis is good. So, love this disease, actually. So, this is our friend Cooper on this picture. He had two techs who were helping him to do some assisted standing and some ball work. And then we did actually put him on our land treadmill and put him over a ball, so he had to, just move his back legs. And these were some of the things that we did with him. We did acupuncture with this dog. We did some manual therapy. We did many, many, many things with him. But these are kind of the most interesting things to look at. So, as I said, we need to remember that we are veterinarians and we need to do our due diligence. If a patient is being referred to you for things like disc issues or some other painful neurological condition, what we need to make sure is that we are dealing with the pain. And even if you decide that all you're going to do is rehabilitation, you're not going to do anything else, and you're not going to prescribe drugs yourself, these patients will come into you on pharmaceuticals. So it's important to know which pharmaceuticals they might be on and what they possibly could be taking, so that you are not surprised by possibly some of the side effects. Now this picture here is, of course, the scream, and I always like to think about chronic pain as being like that. And our patients can have chronic pain with many of these neurological things. So what happens with neurological disease? Should these dogs be on steroids, or should they be on NSAIDs? Well, so here's the thing. From speaking to neurologists, they tell me it's kind of where you were trained. And some neurologists use only NSAIDs, and some use steroids and NSAIDs, obviously not together. And sometimes they'll use NSAIDs if they don't get the response with decreased inflammation they want, then they're going to use steroids. So either are appropriate. But when we are dealing with pain like that, we do need to remember we need to use other things. Now, gabapentin is, of course, for neurological pain. Amantadine and amitriptyline are also adjuncts that need to be, and gabapentin is too. Gabapentin needs to be used with something else, either with an NSAID, with amantadine, with amitriptyline, with tramadol. And yes, tramadol has gotten a bad rap, here in North America after we've had a couple papers that showed that it didn't really work very well. It certainly doesn't work well for acute pain, but it is a selective serotonin reuptake inhibitor, so it can have some place in chronic pain for some dogs. So, and if you are doing a lot of rehabilitation, your dogs, many of them are going to come in on this particular medication. So again, the most commonly used pharmaceuticals, NSAIDs or steroids, still controversial. And remember, the new one, Galliprant, is really for arthritis, and it's not useful at all for nerve pain. And gabapentin or pregabalin can be used for neurological pain. Let's talk a little bit about gabapentin, because we'll assume that your dog is on a steroid or your dog is on an NSAID, not Galliprant, for the inflammatory component of its neurological disease. But gabapentin, what about gabapentin? First of all, don't just use gabapentin on its own. It needs a helper. It works best with something else. Don't use it alone and think, I'm using this for pain. Not going to work. So gabapentin it works on the voltage-regulated calcium channel, and it is a blocker at the dorsal horn, okay? It's going to prevent some of these pain signals from getting through. That's how it works. And it's eliminated by the kidneys, so we must remember that renal patients need lower doses. And our gabapentin dose generally is 5 to 10 mg per kg BID to TID, and you can increase the dose over time, up to 40 milligrams per kilogram BID. So this is what it is. This is what happens. So gabapentin is a very, very safe drug. The major side effect that I see with it is sedation. Some of these dogs can be ataxic. Occasionally the dogs can be dysphoric. Now, the thing in bold print and red is important. Dogs with pre-existing neurological weakness, it may exacerbate the weakness. So you need to reduce the dose or discontinue it. And here, we all want to appear smart. If we have a dog that's on gabapentin, and it's having an issue walking, either discontinue it or taper it down, and they will think you're very, very smart. And sometimes this occurs after the dog has been on gabapentin for months. So that's kind of an interesting thing. This actually came from the pain consultation and referral services at Tufts. I think that this is a great sheet that they have made up, and they gave me permission to use it with you and to use it in my clinic, and they really just want people to use gabapentin and use it properly, okay? And it really tells you about that. So I have actually taken this, reproduced it in my clinic, and I've given it to my associate veterinarians so that they can see what it is. And this also has on the sedative dose that people use now for dogs and cats. For acute pain, I mean, often it's going to be opioid sparing if you're using it right away, preoperatively, and there's really no lasting organ toxicity. And, and you don't have to taper it. You can just continue it for 10 days and you can stop it. But the important things are over here on the chronic side, where we need to lower the dose in chronic renal failure, and we've already talked about the dogs becoming weaker on it. If the dog is currently on tramadol, have them stop the tramadol for a dose or two, because tramadol and gabapentin in older patients could equal a coma. Never seen that, but I have always stopped the tramadol for a couple of doses before I add gabapentin. And then if they still think that they need the tramadol, then you can put it back on there. So here's where you're going to start here and work up. But you can read the rest of this. But you don't really want to abruptly stop it. That's what it tells you here. However, I can tell you that it does not have the same effect in dogs that it has in humans, where you're really supposed to not stop it abruptly. It's better if they don't stop it abruptly, but if they do, it's probably not going to cause a huge problem. So how else do we address pain? Cage rest. How important is cage rest? If you have a dog who has intervertebral disc disease and you are managing it conservatively, cage rest is very important. And what does that mean? Okay, so I have a dog with a cervical disc issue or pain from a thoracic disc. I put it on medication. It seems to be a lot better. I recommend cage rest for the clients of 2 weeks. What does cage rest mean? It means in a cage, period. In a cage, not in a small room. The dog needs to be confined so it doesn't move for 2 weeks. And what can you do along with it? You can do some massage. You can do some heating and icing. You can, if they are in a cage that's portable, you can take it into the veterinary hospital for laser and acupuncture. And those are the things that we would like to do. And I'd like to have the client do passive range of motion with that. I want to do things that are aimed at pain, but what I don't want is the dog up walking and running and jumping around. So now that the pain's under control, what do we do? Well, okay. Client education, we need to set our expectations for recovery. And I always ask my clients, what are their goals for this dog? And we need to make sure that client goals, let's call that CG, match the therapist goals for what the dog really can do functionally. Because this dog that has a T3L3 myelopathy, if it did a lot of frisbee playing, it is never going to go back to frisbee playing because that's going to exacerbate its condition. So you need to have a very good discussion with your client as to what the dog can do throughout its therapy as well as what it can do afterwards. And that's the whole point of doing this particular program, is for you to learn that so that you become a really good therapist. And by the end of the 4th module, you'll understand that. So anyway, we need to set expectations for recovery. We need to look at secondary problems like bladder issues or infections. And the big thing is that we're going to focus on recovery of function, right? And then recovery of strength and addressing correction of the root of the problem. Rehab is a holistic therapy, so you're treating the whole patient and the client. And this is huge. Remember nutrition. I have a nutrition discussion with every single client because most of these dogs are obese, and we will talk about obesity in one of our later modules. Most of them are obese, and they need to build muscle, and they're not active now, especially if we're cage resting them. So we will talk in a later unit about total calories. So for every patient, I figure out the number of calories the dog should eat, either for weight loss, for rehabilitation, or weight maintenance. So, but we will talk about that in a later module, but just remember nutrition. So how about these patients that are down? What are the things that we worry about? Well, we think about the fact that because they're down, that these dogs sometimes are depressed and they are moaning the loss of their independence, and many of them get disuse atrophy, right? And they can have permanent loss of mobility if they're down for too long. So we need to work on that. Remember, these dogs often have chronic pain. We need to address that. Decubital ulcers, urine scald. So what do we do about that? For being down prolonged, we get these dogs up. We put them in a cart. We use slings. We get them up. We move them around. Sometimes we'll put them in the underwater treadmill. We want these dogs to move somewhat. Chronic pain, we're going to deal with that with pharmaceuticals, nutraceuticals, modalities. Decubital ulcers, well, if these dogs are moving around and they're really well bedded and you're getting them up and down, they'll have fewer decubital ulcers. Urine scald, well, sometimes these dogs need diapers. That's just the reality of the situation. So here's some other things, depression or self-inflicted trauma. Depression, because if this dog is just left, in the house and it can't move and it's in a box or it's in a cage for day after day after day. Now, I'm not talking about the 2 week of cage rest, that you might need for the disc issue. But the important thing is to talk to the client and say, listen, your dog needs to recover from this. And yes, we've done the cage rest. We have pain control. We now need to maybe get the dog out with a cart. Maybe we can get it out in a stroller. Maybe we can carry the dog outside. Something like that. Self-inflicted trauma is often because these dogs are not properly taken care of and medicated. They should be on gabapentin, and maybe they aren't because they're getting tingling with nerve sensations, and that's a problem. Now, if they're laying there on one side alone and they're not moving around, they can have reduced lung capacity. And if you're feeding them the same amount, they are going to gain weight. So these are all things we need to think about as a rehab therapist. And we need to help out the client. If the dog's incontinent, dog diapers are a great thing. I have, these are of course disposable ones. You can have reusable ones. They're very easily available now. When I first started doing rehab in 2000, which was like a long time ago, like 20 years ago, I had a lady who made them for me. And you can still make belly bands and things like that, but the reusable ones that you put diaper liners in are very much available. Now, this is an interesting case because it's always good to see, do these things actually work? So let me tell you about this patient. This is Prince, and Prince is a dog who had cervical disc surgery. And he sat in someone's kennel for 4 weeks and didn't move. And they didn't move him. And he came to me and he was a quadriplegic. So here I have two of my technicians, bless their hearts. We have the dog in a sling and they are moving the legs for him because Prince had really given up. He actually was very depressed. He lived in northern Ontario, so they drove 12 or 13 hours to come and see me, and they left the dog at my hospital for a month. And this video I took probably the first time he was in the underwater treadmill. And so as you can see, it took 2 therapists to move his legs, but we have him in there because that takes off a lot of the weight, and we are doing movement patterns. And we'll talk a little bit more about movement patterns. So this is Prince week 2. Look at this. We only need 1 therapist, and he is moving his legs himself. Now she's just there making sure his legs don't splay out and that kind of stuff. But now, what did we do? We did acupuncture with him. We did some laser therapy. We put him in our treadmill. We had him in clinic, so we put him in our treadmill every single day. But suddenly he decided, I can walk. So he's a sled dog. We are in Ontario, Canada. This was winter. He really liked it if he was outside, so we took him out in the snow. And the snow is a very good thing to use to help with conscious proprioception. And look at this dog. He's very, very interested in everything and interested in the snow. And this was week 3. Now here he is, week 4. He's ready to go home. And he's walking around. And the owners, of course, were thrilled about this. So you see, you can do this. So what are some of the things that we can do that are very helpful for these dogs for neurological rehabilitation? One thing that's very, very easy to do is cryotherapy. And if you have a dog that's post-hemilaminectomy or has some kind of painful exercise that you're doing it, we're going to use cryotherapy. We're going to use ice. Now, you don't have to use this cold compression cool thing that we have here, which is like this is from Companion Animal Health, obviously. I mean, there are other things. There's ones called Game Ready and stuff, which are really used most commonly by surgeons post-cruciate surgery. But you can use it anywhere that the dog has a problem. You can ice a dog's back if it's having an issue with IBDD. But what we need to remember is that icing is really fairly superficial. Up to 4 centimeters, it's not going to be much deeper than that. And why is it good? Well, I mean, if you've had a sports injury, you know why that's going to be good, but it's going to cause some vasoconstriction, right? and it's going to decrease your cellular metabolism. Your nerves aren't going to fire as quickly, so you're not going to feel the pain because it's going to decrease your nerve conduction and therefore decrease muscle spasm. So are we targeting the spinal cord with this? Well, no. We have to remember when these dogs have spinal cord surgery that, we were cutting skin, we're cutting fascia, we're cutting muscle, we're going through all those layers to get to the spinal cord, cutting bone. And all of those things have little nerve endings, even though our spine doesn't. And those ones can cause a lot of pain. And you can get scar contraction, and we want to minimize that sort of thing. So you can use regular ice packs. You can use these game ready things. You can make up your own ice packs. And your own ice packs, for that, you just need Ziploc bags. You need some alcohol, and you need some food coloring. And generally, you're going to put in 2 or 3 parts alcohol to 1 part water. I usually use 2 parts alcohol and 1 part water. And some food coloring so you know what it is and you can freeze it. But, we also use the vaccine. In the summer, we'll get these ice packs with our vaccines. A lot of times we will use these. But if you have to make up your own ice packs, you certainly can. So our precautions for cryotherapy are going to be things like avoiding areas that have had frostbite. If you have very old or very young or hypertensive patients, you have to be cautious with that too. If you have superficial wounds or decreased nerve sensation, open fractures, you have to be cautious. And again, we're going to check for redness or blanching after 5 minutes. 15 minutes per session would be the maximum that I would do. I usually will take my ice pack and then I will wrap it in a towel that's gotten wet. You wet a towel and then you wrap it. It tends to work better. And, just as we can use ice with these patients, we can also use heat. So you do not want to use thermal therapy within 72 hours of surgery because we have a lot of inflammation. And our thermal therapy increases circulation, causes vasodilation to tissues, and it's going to improve oxygenation, but you don't want to bring more inflammation to already inflamed tissues. We use it a lot with neurological rehabilitation for painful muscles before exercise or stretching, and also to help improve range of motion. So what kind of heating methods can we use? Well, hot packs, warm water, therapeutic ultrasound, warm water blankets. I would say we tend to use hot packs and therapeutic ultrasound, most commonly in rehabilitation. Warming blankets would only be if we had, a really old patient who seemed to be quite cold and had a very cold back and we wanted to use that. But these are things that we can think about. We often use warm water. Our treadmill, we keep the water for our treadmill and our pool between 86 and 88 degrees because we want to decrease muscle spasm. And many times we're heating up our patients just by putting them in the treadmill. So what about traditional Chinese medicine and acupuncture? So for neurological rehabilitation, we do a lot of acupuncture. And many of you, because this course is given in association with the Chi Institute, may already be certified in acupuncture. And if you are, then that's great. You already have that tool. If you are not, then it's something that you might want to consider. But let me just give you a little bit of an overview about that. Acupuncture is now taught in many medical and veterinary schools. And unfortunately, I was a graduate of the Ontario Veterinary College, and they don't teach any acupuncture there, which is an unfortunate thing. However, there are many schools which do and which employ acupuncturists on staff. Anyway, it's very common that when we're doing neurological rehabilitation, we use both Eastern and Western modalities. And there is a lot of ongoing research on the neurophysiological basis of acupuncture. And it used to be that you could only learn TCVM acupuncture, and now they have something called medical acupuncture, where they basically are teaching that without any of the TCVM principles. I personally, my opinion, I'm in favor of using TCVM principles for acupuncture, but I'm happy if anybody learns to do acupuncture at all and can treat these neurological dogs. So what does this mean? Where are acupuncture points? If we think about it, they are located usually in palpable depressions. They are in areas of low electrical resistance and high skin conductance. And they tend to be where nerves bifurcate or where they penetrate tissue planes. And when I took my first acupuncture course with Ivis, we were playing around with an acupuncture point finder, and I don't use one, but I do understand the theory that they will work because they are picking up areas of low electrical resistance and high electrical skin conductance. But if you've ever used one of those, you know that it will pick it up and it will immediately treat you with a zap. And I can't imagine treating my patients like that and just zapping them, because to me it was far more painful than putting a needle in. So how does acupuncture work? Those of you who do it probably understand how it works, and I think probably my techs get asked this more than anything else. So if you leave your technicians in with your patients having acupuncture done, then you need to make sure that they understand how acupuncture works, because the clients might not ask you, but they will ask them. And this is a picture of my friend Sheila Robertson, and this was her own cat having acupuncture. I could easily replace it with another one of mine, but I kind of like this slide. So anyway, local effects with acupuncture, we get release and effect on neurotransmitters. Our acupuncture is affecting the dorsal horn of the spinal cord, and it's affecting our A delta fibers. So what happens with that? That has to do really with the gate theory of pain, where we have stimulation in the periphery by the acupuncture needle through the A delta fibers, closing the pain gate and inhibiting the C fiber activity. Now there's also local release of enkephalins and serotonin. So we have local effects, and we also are going to have systemic or global effects. And our systemic and global effects include release of endorphins and also release of serotonins. So how does this work? If we think about TCVM acupuncture, and all of these are my rehab patients, and most of these are disc dogs. But anyway, if we think about the TCVM, we talk about stagnation, we talk about acupuncture, affecting things like yin and yang, and we're treating for excess and we're treating for deficiency, and we know that we have our meridians, and we know that we're stimulating the flow of qi down the meridians past the areas of stagnation, and that's our traditional Chinese medicine thought about it. But the medical acupuncture people, and I do lecture to a lot of non-acupuncture veterinarians who want to know about how this works. And now this paper is not that new. It came out in 2002, and it talks about the relationship of acupuncture points and meridians to connective tissue planes. And they think that perhaps the network of acupuncture points and meridians has to do with how interstitial connective tissue works. And they've actually gone through and looked at this, and they've done ultrasound images, and they've done dissections, and they found that there are acupuncture planes that run down the bladder meridian, from the head all the way down to the back foot. And it's very, very interesting, this work that they're doing. And this came a lot more to light when they started to realize that the interstitium was an organ, and that they realized that, there's things that go on in this space between the muscles. But there's a couple of very interesting newer journal articles, and I have one down here for you about evidence for a mechanotransduction-based mechanism for how acupuncture works. And a summary for this is that we have the needle grasp that's going to cause matrix deformation. It's going to increase our intracellular phosphorylation, which is going to increase signaling. There's going to be an increase in growth factors, such as transforming growth factor beta. And it's going to increase enzyme production and protein synthesis. So really, our connective tissue is deformed. And there's a release of growth factors, proteins, and neurotransmitters. And then the fibroblasts and the loose connective tissue respond to the stretch. So within minutes of inserting your acupuncture needle, you have an increase in ATP, and you're going to enhance the relationship with your neighboring cells, not just the one that got stuck with the needle. That one sends out signals to the ones next to it. And this is really a powerful modulator of our intrinsic healing in soft tissue. So it's going to affect our skin and muscles, tendons, ligaments, fascia, cartilage, periosteum. So these are very, very important. And this is really a summary of that paper that I had cited that's really showing the effect of the rotation that peaked when they put the needle in with 2 needle revolutions. And it was going to decrease with further increases in rotation. And the rotation effect of that one acupuncture needle was present throughout the tissue over several centimeters. And the part that I put in black is something to really put into your mind and think about, that the active cytoskeletal response of the fibroblast that was demonstrated in this study is an important step to understand cellular mechanotransduction responses. So the fact that our needle is going into one spot, but it's causing mechanical stimulation through the whole tissue. And that supports our previously proposed model for the mechanism of acupuncture involving connective tissue. So that's the little theory about how it works. Here's one of my cat patients having acupuncture, and I treated this cat for intervertebral disc disease, but also it ended up with some constipation, and we treated this cat with acupuncture a lot. But anyway, we use it in neurological rehabilitation really for pain relief. It can be used for surgical analgesia. I don't use it for that, but it can be. To increase the rate of nerve regeneration. That's why I'm using it. And to cause an autonomic nerve response. The other thing is we will talk about a little bit later about motion generators in the spine of the quadruped. Now, motion generators are these little neurological centers, and they exist in us, but they only exist in the brainstem and up here, whereas in the quadruped they exist throughout the spinal cord. And one of the things that we can do with acupuncture to help cause our autonomic response and increase our nerve regeneration is it will wake up those generators of motion. There are a few things that wake them up, but acupuncture is one of them. Doing repeated PNF patterns, which we'll talk about later, that's something else that wakes up the motion generators. But they exist throughout the spinal cord, which means you can have an animal with a transected spinal cord or severe spinal cord injury that possibly can walk again if they become something called a spinal walker. So they will have walking that's not under control of the brain. It's only under control of the spine. And I'll show you some videos of those. But it's a very cool thing, and I've been able to get many, many of my patients to do that. The clients don't really care if the dogs are spinal walkers or regular walkers. They had a dog that was paralyzed, and it can walk, and it can still go on walks with them and walk in the backyard and doesn't have to be in a cart, and they're thrilled with it. So, but acupuncture really helps for these particular cases. So what else is it going to do? Well, I mean, it's going to improve circulation, inhibits nociceptive transmission, so decreases pain, reduces muscle tension, spasm, and this is the big deal. It helps to reset the proprioceptive mechanism. and helps reset structural posture, and it's going to affect the autonomic nervous system. So the chemical signals that we get from needle insertion. So we have metabolic changes that happen when the needle goes in. You know, when we have winding, and this is a little electron micrograph of what happens when you stick an acupuncture needle in. And we'll have further input into these mechanoreceptors, and it will amplify our signal. And of course, we also have the stretch fibroblasts and the microtrauma. But in essence, all of this results in neuromodulation of the local tissues and associated neurological structures. So here's our remote effects of acupuncture. We talked a little bit about this, but vagal effects through dorsal motor nucleus, our increase in circulation, our motor trigger point effects, our effects in the blood, affecting blood flow to increase circulation, extracellular fluid effects. So very, very many remote effects. And this was a research paper that was put out by Dr. Qingming Liu from Taiwan, who I met, and I hadn't realized that I cited his paper until he came up afterwards and told me that. But anyway, this is a very interesting retrospective study that was done to determine the most effective treatment of cervical IVDD with acupuncture, and it was hoping to standardize a protocol with this, and they did 3 different things. They did dry needling with local points, electroacupuncture local and distal points. And so half of the dogs got double P2 as well, and that's your Jingtang formula, and also cervical formula. And these were the points that he used for his cervical IVDD. And his results were that the speed of recovery for these dogs with cervical disc disease, well, it depended on the severity of the disease, but if they had just grade 1, they only needed dry needling. The grade 2 and 3 did improve on average 8 to 10 days with a mean of 25 to 35 days, and they needed twice weekly treatments for those ones. The dogs that also received Chinese herbs had improved time to ambulation, and Dr. Liu felt that rehab likely would improve time to ambulation, but it wasn't really proven in this particular paper. So what type of pain conditions are we treating in rehab with acupuncture? Well, musculoskeletal and neurological conditions. I mean, arthritis is not a neurological condition, although we do use gabapentin with it because phenotypically it acts like a neurological problem. And then IVDD, FCE, nerve paralysis, back pain, lameness, tendon injuries, laminitis we don't see in our small animal patients, but it is certainly something that is treated with acupuncture. And of course, I would think intervertebral disc disease is the one that we treat most commonly with neurorehabilitation with acupuncture. And I'm always happy to point out to my colleagues who don't believe acupuncture does anything that there was a study presented in JAVMA that showed chronic thoracolumbar disc disease responds to acupuncture equally as well as with surgery. So I find that a very interesting paper. And so this is Buddy. Buddy is a little pug who has IVDD. He is a T3L3 myelopathy. He came to me from a rescue group. His owners could no longer deal with him. He did have, in addition to having some non-ambulatory paresis in the back end, he had an upper motor neuron bladder. So here's Buddy when we first saw him. So we are getting him to stand, and he's not super successful, rather weak in the back end. We have to hold him up. So as it happened, I adopted Buddy. So Buddy's had lots and lots and lots of rehabilitation therapy. But at this point, when we first got him, he couldn't stand at all. And this is after I'd been treating him with acupuncture and underwater treadmill for about 2 weeks. And so he's moving those back legs. Look at that. And of course, this is not a video. Of course, we put him in our underwater treadmill. That was one of the things that we did. He's also wearing this medical pet shirt, and the medical pet shirt really helps these dogs who have T3L3 myelopathy because it helps connect the part of their body that works properly with the part that doesn't. So it is something that I do use a lot with my patients. And this is Buddy, about 3 or 4 weeks later. Buddy is actually a spinal walker. But hey, he's walking, and he's actually doing a lot better than that now. But this was pretty good. So you can take these patients who really can't walk, and you can get them to walk again. So what else do we use other than acupuncture and our underwater treadmill? Well, we use a lot of laser. It's a very common modality, and it's used in a lot of neurological cases. Why? Because it affects the mitochondria, and it increases the microcirculation and accelerates healing. The other thing it does is it promotes axonal sprouting of the nerves. So this is pretty cool when you can see that this is the clinical effects of photobiomodulation. It is also supposed to help with myelin formation. The other thing it's going to do is increase cartilage and increase bone formation to help with bone repair. So we do use it in a lot of these dogs post-hemilaminectomy, and it seems to work quite well. There have been a couple of studies done that showed that laser helped improve time to ambulation in animals with hemilaminectomies. But what happens is when enough cells receive photobiomodulation, it initiates a biochemical cascade of events that results in a reduction of pain and inflammation and an increase in microcirculation. Therefore, there's an acceleration in tissue repair and wound healing. And so we see this a lot, and we use this a lot in these Hansen type 1 and type 2 disc compressions. Now you see the one on the right, and that one would have been hard to treat medically, and obviously this is a post-mortem. It's not the same dog that's on the left. The one on the left is one of my dachshund patients with a T3L3 myelopathy. But very interesting, and we'll talk later about degenerative myelopathy. And as of right this moment, there was just a paper that was published, a retrospective study on degenerative myelopathy, showing that high-dose laser has a huge effect on degenerative myelopathy in dogs. And I will make sure that there is a copy of this paper when I get a copy of it placed into your notes. But this is really the end of this particular installment, and we will have one more lecture, our lecture number 3 on neurological rehabilitation.